Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. According to the American College of Cardiology, an estimated 47 million Americans are living with cardiometabolic disorders. This puts them at increased risk of heart disease and type 2 diabetes. Now, new research shows us that patients with cardiometabolic disorders also have a higher risk of not only developing COVID, but developing COVID-related complications. Here to discuss this with us today is Dr. Stephen Kopecky, cardiologist at Mayo Clinic. Thanks for being here today, Dr. Kopecky. I know you've been on the show many times before, preceding me, and so it's a delight to have you back.
Well, it's wonderful to be here. You look like you're doing a great job from everything I've seen.
Oh, well, thanks so much. Dr. Kopecky, for me and for the audience, could you tell us what are cardiometabolic disorders or diseases?
Yes, cardiometabolic includes two things. It includes the cardiac disease. You know, if you have heart disease or narrowing of the arteries to the heart, if you have irregular heartbeats like atrial fibrillation, if you have heart failure where your heart fails to pump well enough to meet the body's demands. We've also added to that metabolic disease, which is basically obesity, big abdominal paunch, you know, the guy that walks around with too much of his belt, because that leads to diabetes. And the number one reason, in fact, 85% of diabetics die due to heart disease. So it's really two things that are together. We put them together for these purposes.
What other long-term conditions can affect or increase the risk of COVID-19 infection or complications?
There are other diseases that occur, such as, lung disease, certainly, because it's primarily a lung problem. You can look at things like polypharmacy, people that take one medicines versus 10 medicines. Things like age is certainly a big issue. The older you are, the more likely you are to have problems. So it's a bunch of chronic diseases, we call it.
Some of the illnesses that you described are things that affect different ethnic groups a little bit differently. And I'm wondering, is there a difference in how ethnicity affects COVID-19 and how it affects the patient?
Oh, it clearly is. If you look at ethnic groups, they have a higher risk. Blacks, especially African Americans, have a higher risk of getting COVID and of having complications from COVID. And then you put on top of that the cardiometabolic disease, which is the number one disease for having you have problems from COVID. And that's a real bad combination in terms of increasing risk.
Why is heart disease so deadly when combined with COVID-19?
Well, probably because of the way COVID works. And people have said, well, maybe it's because of the ACE, the angiotensin converting enzyme receptor. And many people are on ACE inhibitor drugs, but that really is not it. It may be that the ACE receptor is on the heart, but it's also in the lungs, it's in the kidney, it's in many places. But what really looks like the major issue, and there are two issues. One, the major one is that when you get COVID, it's primarily a respiratory disease. You get low oxygen in your blood. And the poor heart, remember, has to pump blood to all the body, plus it has to pump to itself. And the purpose is to pump oxygen around the body. And if there's less oxygen because the lungs aren't working, the heart gets less energy and it has to work harder. So it's a huge stress on the heart. The second thing is that sometimes the COVID will actually attack the heart muscle and cause heart muscle pumping function problems, which is a real disaster.
You and I were chatting just a little bit before the program about this next issue, and I found your response fascinating. Are people with chronic diseases likely to follow COVID-19 related health precautions like mask wearing, hand washing?
If you have cardiometabolic disease, you're more likely to die or have complications. We know if you have cardiometabolic disease, you're more likely to get the infection. But now the data has shown that of different types of diseases, like cardiometabolic, or maybe you have you're immunosuppressed because you've had a transplant and you're on drugs, maybe you have mental health problems, maybe you have lung problems, allergies, of those different diseases, and they look at the COVID healthy behaviors, which is the things we've all been trying to do the last 6 or 8 months. Wear a mask, social distance, wash your hands, etc. In the 10 categories of COVID healthy behaviors, the people with cardiometabolic disease are worst in 8 of the 10 categories, meaning they have the least COVID healthy behaviors. And that causes a real problem.
That really surprises me. I would think that people who knew they could possibly become more ill would be very concerned about developing the virus.
The cardiometabolic disease is primarily a lifestyle disease, we call it. 90% of cardiometabolic disease is things that we can change, like our stress levels or our weight or our exercise or what we put in our mouth to eat. And maybe these cardiometabolic patients are saying, I'm going to do what I want to do. I'm not going to really pay attention to what's really my best parts from my health, or I don't know how to improve my health. I mean, that's the real problem. People don't really know. And sometimes it's very difficult. So I think that what we're hearing or seeing is that cardiometabolic disease is a lifestyle disease, and to a certain extent, COVID-19 is a lifestyle disease also.
What can patients with chronic conditions, and especially those with cardiometabolic disorders, do to help decrease the risk of developing COVID-19?
When I talk to my patients now, because I see many with high cholesterol, I say, in a couple of databases, we've seen that patients that are on chronic statins before they get COVID have less complications, meaning that they have a less chance of dying, about a 30% less chance of dying, and about a 50% less chance of needing to be put on a respirator. And so when we look at these big databases, we say, well, is it really real? I mean, maybe they treated the people on statins more aggressively, so they did better. But again, they only needed intubation or put on a respirator half as often, so they didn't treat the statin patients more aggressively. In fact, they treated them less aggressively. And the second thing is there a pathophysiologic reason? Is there something in the body going on with statins that may show why it's beneficial? And what we've seen is people that they're on statins have less inflammation as judged by high sensitivity CRP, and they have lower levels of inflammation. We know that's the major way that COVID affects us, is the cytokine storm that comes about 2 weeks after you get the infection.
So Dr. Kopecky, you mentioned that statins may decrease inflammation and affect a certain lab tests, but can you explain just a little bit about exactly what a statin is and maybe an example of one and what you specifically treat with it?
The statins are the HMG-CoA reductase inhibitors. That's a fancy word for a medicine that lowers cholesterol. They came out in this country first in 1987. The first one was lovastatin. The more common ones we hear about now are simvastatin, atorvastatin, and rosuvastatin, which are all generic now. We don't have really any major brands left in statin world anymore.
Dr. Kopecky, why do you tell your patients with heart disease that it's very important for them to get a flu vaccine?
What causes a heart attack is inflammation or something that irritates the lining of our artery, because all of our arteries have a lining, kind of like wallpaper on the wall. And if you tear that lining due to infection or due to high blood pressure or cholesterol, the blood can be exposed to what's beneath the lining and the blood will clot. And a clot in an artery is like a cork in a bottle and closes off the blood flow. So we know that if you get the flu, you're more likely to have a heart attack within a couple of weeks. So because it's inflammation, systemic inflammation all over your body. The classic thing is surgery. The surgery is an inflammatory, if you get surgery, there's a lot of inflammation in your body and you're more likely to have a heart attack a few days later. And we've also seen that if you get the flu shot, you're less likely to get the flu, which I don't really tell patients I'm so concerned about. But if you're less likely to get the flu, you're less likely to get a heart attack. So I tell my patients, please get a flu shot because I don't want you to get a heart attack. And they say, what? Well, gee, and tell me about that. And I think that does help them understand the importance of getting a flu shot. And there is this entity of two infections at once. If you got the flu and then you got COVID, that's a double whammy, and could be real troubles.
Do you have to have a severe case of COVID-19 to have this potential damage to your heart? And is the damage like long lasting, or does it typically decrease after the COVID infection is gone?
Well, we do see a couple of major types of damage. One is just the overwhelming decrease in oxygen, and the poor heart has to work so hard that it gets damage to the heart muscle because it doesn't get enough oxygen. And that can hopefully be transient. Now, the thing that we're starting to see in a few percent of patients is what's called myocarditis. Myo is muscle, card is the heart, and itis is inflammation. So it's inflammation of the heart muscle. And the supposition is that the COVID is directly attacking the heart muscle or affecting it. And we know that studies with looking at magnetic resonance imaging, or MRI, which is a common imaging modality we use, has shown that over 3/4 of patients that get COVID, even if asymptomatic, can have some evidence of heart damage, mild heart damage, on the magnetic resonance imaging scan. Now, the thing we don't know is how long does that last? The studies are ongoing now, but we do know that patients may have minimal symptoms or may have a normal echocardiogram, which is our sound wave test. We look at hearts and see how well they pump, and they can look pretty good, but the MRI can show something different. So we're learning about this as we go. But if a patient comes to me and says, I'm having trouble with breathing, 2 months after COVID, I think we need to look further with some of these other more sophisticated imaging tests.
I've definitely learned today, and I think a great cautionary tale that people still need to be taking this really seriously. The cases are up in the United States, and we're going into flu season as well.
Very true, and I think people are starting to understand that. There have been a few reports out from insurance companies and from health systems that have said that in the first 6 months of 2020, the people signing up for bariatric surgery, or the surgery that helps you lose weight, went down. But now, this summer, and now it's a 40% increase. Actually, it's shooting up because people are understanding they need to lose weight quick in order to lower their risk of both getting COVID and having COVID complications.
Our thanks to Mayo cardiologist Dr. Stephen Kopecky for coming today and sharing with us about COVID and the heart.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on podcasts. Thanks for listening, and be well.